Thank you for your very kind introduction and invitation. Good afternoon. I hope you got a chance to get some really good coffee and tea and get yourself ready for another very interesting and very exciting session. So I'm Shu-Sen, I'm Professor and Director at the Institute of Health Behavioral and Community Science at College of Health at NCD. It's my great pleasure to introduce our speaker, Professor Takehiro SUGIYAMA. He is Director of the Department of Medical DX, aka Digital Transformation, at the Japan Institute for Health Security, and specially appointed professor at the University of Tsukuba. Professor Sugiyama is a physician scientist specialized in health services research and primary care. His research focuses on asset 2 and the quality of care for NCDs, particularly diabetes. He has extensive experiences using large-scale real-world data, including national health insurance claim and health checkup databases to evaluate healthcare policies. He is also closely involved in Japan's medical DX initiatives, with particular interest in personal health records, digital health, and data-driven behavioral change. He also contributes to the national health policy through advisory work with the Japan's Ministry of Health, Labor, and Welfare. So we have exactly the right person to tell us how we turn a great deal of health data into something that actually changes what people do. So today, Professor Sugiyama will speak on PHR research and evidence from Japan, analyzing multi-source data for behavioral change. Please join me in welcoming Professor Takehiro Sugiyama.
Good afternoon, everyone. I'm Takehiro Sugiyama from Japan, and from the Japan Institute for Health Security and University of Tsukuba. I want to talk about the PHR research and evidence from Japan. Yes, this is my conflict of open interest disclosure. Yes. Personal health record. So when we talk about PHRs, everyone is picturing something different. So when I talk about PHR, I think the classic definition of the PHR is looking at their personal health record in the the health checkup data or the electronic health record. But sometimes they are exchanging this data. So definition of PHR in Japan is that number one, health checkup information. This one? It is given to the individuals through the minor portal. So minor is the abbreviation of the my number. So there the infrastructure from the government that these data are provided through the API system. And another one is so from medical institutions through the electronic health records. The information are provided to individuals. And I think they are simple definition, but this number 3 is after collecting data by individuals themselves, these information are provided to the physicians in the medical institutions. So I think the things are complicated, I think. And I want to talk about the minor portal, the PHR gateway by the ministry. So, minor means my number part. This is the card and the digital infrastructure made by the government. And this is not mandatory. So all numbers are given to the all citizens, but whether they want to they have the card or not, whether they use the portal or not, it's arbitrary. They can have access, but they don't need to do that. But they can check up the result from that portal, and they can check their medical cost, and they can check and give the information to the physicians at the hospital about the prescribed medicines, and the information about the hospital visit on the vaccination. This information are recorded in this minor portal, and we can share it to the healthcare providers with our consent. And I want to talk about the digital therapeutics and the PHR in Japan. I think we have 3 tiers. The number one, first tier is the digital therapeutics apps. So this is reimbursed applications. So smoking cessation and hypertension and drinking reduction. These apps are reimbursed from the insurance. So this is like the medication. If a physician prescribes this application, they get reimbursed. And another one is the bundled device. Yeah, so like because I'm an endocrinologist, I'm using this application very often. But diabetes intermittently scanned CCM, continuous glucose monitoring. These things are reimbursed, but this is part of the medical management fee. And another one is the voluntary health app. This is not the reimbursed, so on the insurer, but this is for the prevention mainly. So insurer can provide this health app, not from the reimbursement, but they can subsidize this application through the insurance system. And the municipally provided one is there, so students can have access to this application through the local government. And also self-downloaded one is there. But I think these applications are reimbursed, and of course they are evidence-based, and but these are not so evidence-based, and so the evidence is very thin. So I want to talk about this information. I bring 2 examples of these applications. So I want to talk about the mechanism from the PHR use to changing attitude and changing health behavior, and after that there can be a health improvement. So we had a study project from fiscal years 2013 to 2023 to 2025. So the first aim is to check whether check who will use these applications, and the second one is how much will the PHR change their health, and the third one is who will be susceptible to these mechanisms, who can have the health outcome the most. So male or female or younger one or older one or these things. And these things are based on the trans-theoretical model. And first, we conducted an umbrella review of the review articles about the PHR and the behavioral change. And we collected 12 review articles in the umbrella review. And what we found in the umbrella review is that there are some factors associated with the PHR use, like higher education and income, also male and younger, and white persons and insured persons. And non-use is the like the providers are underprepared, and if patient expectations are too high, they will drop out. And tethered PHR. Tethered PHR is the what we talk about, what I talk in this slide. So this flow, so looking at the health checkup data and the medical institution data, these are the tethered PHR. And sometimes they improve the glycemic control, and also sometimes blood pressure or LDL cholesterol, but others are not. So they are quite marginal effects. And others are messaging with providers and prescription refill. These can change their behavior, like the regular visit and better glucose and the LDL control, or the link to the better medication adherence. So I want to introduce a couple of PHRs from Japan. One is Calmir. This is a dietary app, meal tracking. So as I see in the Singapore example, this is the AI photo recognition, and also it has the barcode scanner. So if we check the barcode with this application, we can know the calories and the salt intake and these things. And this is the totally private sector, and each person can download from the App Store. And PEPAP, this is from the health insurance company. So health insurance company have the contract with this company, GMDC, and the beneficiary of the insurance can use this application for free. So this is the health portal, and you can check the health data from that application, and there's a point and incentive by doing the health recording or the reading the plans and these things. And column. So when we take a picture of this food, you can calculate the calorie and these things and these things. Using this data, we conducted a retrospective cohort study when they get started using this application. A survey is automatically sent to the users, and these surveys are sent after 1, 3, and 6 months later. So new user columnists are this is the characteristics of the new users of the columnists. So this about 6 months, there are 470,000 new users of this application, and many people are young, right? They're in their 10s or 20s, right? And some people use the team feature. So some participants make the team with some other participants, and they can share the information about the eating logs or the weight log or these things if you want. And this application is mostly free, but if you pay a little bit of money, you can get extra function. So paid plan is like 1.4%, very small amount. And this is trend in continued use. So retention rate is unfortunately not so high. So retention rate is so just after starting using this application, many people stop using this one, right? But male people are more continue using this application than female people. Or younger people tend to stop using this application than older people. And team feature are not so different clinically, but there's a statistical significance. And those who pay for this application rather continue to use this application. And we want to see the outcome of the continued use of this application, and we have data about the weight and calorie intake or these things, but we only have the information for the continued users, right? So what I showed today is about the change of the attitude. So at the start, this is the attitude for the health promotion in the trans-theoretical model. So the most part is at start is intended to improve soon. But after that, 1 month, 3 months, 6 months later, they get to the already working on it, right? And self-confidence about the working to improve your lifestyle. So at the start time, they are not so confident, but after that, they get somewhat confident. The proportions are larger after using this application. So summary, so attributes linked to continued use are the males under age over 40s and use the team feature a little bit and subscribe to the paid person. And within 1 month of studying, user advanced in their stage of behavior change and confidence. And I want to talk about a pep-up. Pep-up is, as I said, there's some columns and they can record their steps, walking steps, and they can calculate the healthy age, and they can record sleep time. And this is given from the insurance. And I will skip this information. And yes, just a little bit about the blood pressure or the triglyceride or the LDL cholesterol or hemoglobin A1C. There are a little bit of change. I think these are very small amount because they include normal, healthier persons, rather than the patient with diabetes or a hypertensive patient or these things. So, and we stratify this data to the people with diabetes or hypertensive patient. We saw the larger effect. And the degree of the use of the PHR and the behavior like the smoking cessation or the alcohol intake or these things, there are some dose response relationship here. So I think this shows the relationship between the PHR use and change of the behavior. And I want to talk about the linkage with the insurance data and questionnaire because the data application can be a platform to have the questionnaire survey. I think it should be a big chance to the public health persons, I think. So as we see in the common example, many PHR systems have the survey functions. The insurer provided system has claims and health checkup data as well as PHR data. And screening using claims and health checkup data enable us to focus on a group of certain disease or health conditions. I want to talk about the diabetes example. Yes, so I'm as I said, I'm an endocrinologist, and I have a chance to conduct a survey for the people with diabetes. But I was not sure how to collect the, how to sample the usual or ordinary diabetes patient from the many of the patients in Japan, right? So there are 10 million patients with diabetes in Japan. And if we look at the patient group, these people have their own opinion and they have many knowledge about the diabetes. So it's quite different from what we want to capture. So, and if we want to have access to the patient with cancer, at that case, patients are centralized to the big hospital, and and if we collect some of the hospital, we make the survey there. It's rather easy, but for patient with diabetes, patients are not centralized, and there is no patient registry in Japan about the diabetes. So if we capture some of the people, we cannot generalize that information to the population. So what we've done in 2022 is the collaboration between the Tsukuba City, University of Tsukuba, and the National Center for Global Health and Medicine, currently Japan Institute for Health Security. So we received the data from the Tsukuba City about the claims data and the health checkup data, and we chose the candidate for the survey from this information. So we made a list of the people, and they conducted the survey by the Tsukuba City. So Tsukuba City is the insurer of the municipal insurance. So they hold this information. And after that, they linked this information to the survey, and we analyzed this data. So we here we go. We sent 1,000 copies of the survey, and we received 456 people. So the response rate is like 46%. And we calculated the response rate by strata, and we calculate the weight from that, and we can rate back this data, and we can generalize this information to some extent. So we approach the difficulty of people with diabetes with this information. Do you feel anxious about the future because of the diabetes? So, about 50% of people feel that they answered yes. And about the understanding and prejudice. So, the question about the society has prejudice against the diabetes. Here, type 1 people with type 1 diabetes answered 38% say that agree, and 20% agree about type 2 diabetes. So we can use the health claims data and the health checkup data as a register of the registry of the patient with diabetes. So we call this mechanism or the sampling method as claims-based enumeration sampling, and we wrote a methodological paper. And I think we can use the application PHR or these things as the platform to make this patient survey, or and if you have this registry or this claims data or this basic information, you can wait back to the more generalized population. And I think it's a good way to ask things to the sampled persons, and we can proceed evidence-based practice based on this information. So yeah, this is a wrap-up slide. So evidence is still scarce. The evidence base for PHR in Japan remains very scarce, and following X users is very hard, right? So because many times, in most situations, we don't have the data about the X user, right? So if they quit using the application, we cannot follow up their weight status or calorie intake status. So in that case, it's very hard to follow up the effect of the using the application. That's the hardest point of my research project. And insurance-based PHR has a linkage. So if that PHR information is linked to the insurance claims information or health checkup information, that can change the game, right? So at that time, you can check the effect of the PHR by connecting the PHR data and the claims data or health checkup data. And if you can connect these, if you use the platform as a patient registry, you can connect these PHR data and the survey data, and we can get a lot of information for the public health, I think. Okay, this is the end of my presentation. Thank you very much.
Thank you for your very interesting presentation. So we have some time for some questions, feedback, comments. Okay, maybe I start with a few questions. So this very interesting and based on very large sample. And so in terms of the association between PHR use and health outcome, is this, in terms of the magnitude of the association, the magnitude or the strength of the association is in keeping with your expectation, or is smaller or even larger compared to existing evidence? And the second following question is, if there is any association, would that be explained by because of the use of the PHR or other characteristics? So it's very likely that people who are more health conscious, they may more likely to use the PHR, and at the same time they have better health outcome. So how could we have a more in-depth understanding to what extent this association being explained by the use of PHR itself? Thank you very much.
Thank you very much. The first question is about the magnitude of the effect or the use of the PHR and the outcome. So it's very small in terms of the blood pressure or the glycemic control. But as I said, it includes the healthier persons. So they are not patient with all the patients are not patient with diabetes, or all patients are not a patient with hypertension, but many general healthier population decrease their blood pressure like 1 millimeter Hg, right? Yeah, it's very small, but if the population shift a little bit, I think the magnitude is quite large. But the point estimate of the effect is very small. But it means that it can change the population health. I believe that we can see these effects in population. And when we focus in the more severe population, like the patient with diabetes or patient with hypertension, we see like the 3 millimeter Hg or the so more profound effect. So I think if we say that this is a therapeutic effect, I cannot say that because when we talk about the effect, therapeutic effect, as you said, we cannot talk about it with these observational data sets. And if we say like the therapeutic effect based on that, we need to shift to the digital therapeutic apps, right? So we need to get the reimbursement from that. And so this is like the health tablet under medication. I think this is the analogy, right? So health application or digital therapeutics, this is a distinct difference. So we cannot say that this is the effect, but there is some relationship there. And I think this distinction is associated with the second question, right? So when we see the observational data, as you said, there is some confounding by indication, or if people want to use this application, they are more health conscious, or and after that, they can change their behavior and they get more healthier. We want to control for this covariate by including this data in the multivariable modeling, but I think we cannot rule out all of these effects. So it's very hard to do that, but of course, if we want to see the effect on that, we need to do the experimental study based on this application. Yes.
Yeah, thank you. Yeah, I look forward to future research to be able to address those questions. So, given the time, so I think we need to move on to the next section. So, to conclude, I thank you again for your very interesting talk. Thank you.